Good evening, everybody. Thanks for coming out tonight for this session. We're really excited. I'm excited to be partnered with Sarah tonight. We've never worked together as a team, so it's been a fun collaboration to put this together. And we were excited we wanted to bring you some kind of freshened up, newer data about lipids, share some new interesting studies, and some new compatibility data that we hope is going to be very helpful for you in your practices. So tonight's event, of course, it worked and then it didn't, but that's okay. I'll just go back to we're frozen. There we go. Okay. Computers, can't live with them, can't live without them. So anyway, this is an event that's being sponsored by Fresenius Kabi. It was through a grant to SCCM. We got to put the slides together completely on our own, though, and they didn't have a role in this. These are our other disclosures. So what we're going to be talking about tonight, so we're going to do an overview. First, we're going to talk about just the lipid emulsions and a little refresher for those in the room who maybe aren't doing this on a daily basis about what the lipid emulsion options we are here, or what we have in the US as well as some around the world. Talk about some of the newer clinical evidence, some of the new trials that have come out, some of the new meta-analyses, look at some of the recent clinical practice guidelines, and then share that compatibility data that I talked about. Of course, we have a lot of abbreviations, so I'll share this with you, but basically, I think when we speak, I won't be throwing out too many letters at you, but feel free to stop us too if something just totally doesn't make sense. But we're going to be talking about pro-resolving mediators and a few other things like that. So, Sarah, I'll let you take it away.
All right. Sorry, excuse me. Thank you, Dave. So my name is Sarah Kogel, and I'm an adult nutrition support pharmacist and burn ICU pharmacist at Vanderbilt Medical Center in Nashville. So just to kind of get everybody refreshed a little bit about lipids, some basic lipid facts. We know that we use them as a nutrient source and to prevent essential fatty acid deficiency. They're a really dense source of kcals. They have 10 kcals per gram. And they provide our essential fatty acids, linoleic acid, and alpha-linolenic acid, so LA and ALA, the more of the alphabet soup that Dave was referring to. Lipids help us deliver lipid-soluble vitamins, and they're also involved a little bit in the inflammatory and immune responses, as we're going to talk about later. Another thing to remember about lipids is that they are formulated in an isotonic solution, which means that they are very favorable for microbial growth if they're infused by themselves, and that's why they have some very specific handling and administration practices that need to be followed, and we'll get into that a little bit later as well. Whoops, wrong way. Okay, so when we think about the history of lipids, I read today actually that the first time they attempted lipids was in like 1672, so we don't have a lot of great data on that, but I don't think it went super well. In the 60s, they formulated a cottonseed oil lipid emulsion that caused a lot of very negative reactions. It was pulled from the market, and then eventually they were able to formulate single oil products, which were soybean oil or safflower oil, although safflower oil was removed from the US market in 2010, just as the practice of using soybean oil was much more common at that time. In Europe, they have had a lot of other lipid formulations available for quite some time. They added MCTs, which are medium chain triglycerides, to the soybean oil, and that helps improve their stability, and also, as we'll talk about, have some different immune effects. The third generation lipids are the soybean oil and olive oil formulations, which have fewer omega-6 fatty acids, which we'll talk about. Those tend to be more pro-inflammatory. And then our fourth generation lipid emulsions that we're going to be referring to a lot tonight. I know these are a lot of acronyms. This is the official way you're supposed to refer to them in writing, but the 4-oil, which is SMOF lipid, so it's soybean oil, medium chain triglycerides, olive oil, and fish oil. And then there's also another fourth generation product is 100% fish oil, which is Omegavin, and is used mostly in pediatric patients. So as we think about why we transitioned and why there was a need to move from the first generation down to the later generation oils, soybean oil is great because it has a lot of essential fatty acids. So that is good for preventing essential fatty acid deficiency. We know that our patients have to get lipids. But the problem with soybean oil is that it's more pro-inflammatory. It could actually act to suppress the immune system, and we may see more cholestasis due to the higher concentration of phytosterols, which impair bile flow through the liver. So then we added MCT, or medium chain triglycerides, in. With MCT, we're going to see less accumulation in adipose tissues and liver, and one of the differences between soybean oil and MCTs is that they don't produce pro-inflammatory mediators. We have olive oil, which is considered to be immune neutral, so it's not anti-inflammatory, but it's not pro-inflammatory like soybean oil. And then lastly, we have fish oil, which is thought to be anti-inflammatory, and it also contains omega-3 fatty acids. So these are the products that we have currently on the market in the United States. In other countries, there are different types of lipids, but we're kind of limiting our talk tonight to the ones available in the US. You can see for a long time in the US, all we had was soybean oil-based lipids. So that's going to be our Nutrilipid and Intralipid. There's a higher omega-6 to omega-3 ratio here, and the dosing for these, particularly in critically ill patients, should be less than 1 gram per kilo per day. Then we have clinolipid, which is an olive oil, soybean oil combination. And so it does have a lower concentration of soybean oil than smofflipid, which is listed below it. But if you look at the omega-6 to omega-3 ratio, you see that it doesn't have the omega-3s with the fish oil added, so that ratio is actually quite a bit higher. When you look at the dosing of clinolipid and smofflipid here, you can see that these are dosed quite a bit higher than our traditional soybean oil-based lipids. So when we think about fatty acids, I mentioned that we want to give lipids so that we have an energy source and something that can be used later to supply energy. But lipids have other functions besides this. So we have enzymatic activity that can act in the inflammatory response and also in the response to resolve inflammation, which we'll talk about a little bit later, and Dave's going to share some data on. We can also see cytokines and immune system function affected by our fatty acids. So I mentioned that the 4-oil product smofflipid contains omega-3 polyunsaturated fatty acids, or PUFAs. These are EPA and DHA, and they occur naturally in fish oil. And there are a lot of proposed actions for these PUFAs. They can reduce oxidative stress. They've been shown in some studies to decrease inflammation. And they also generate something that are called pro-resolving mediators, which can actually resolve the inflammatory response. These specialized pro-resolving mediators, or SPMs, as I mentioned, are produced from EPA and DHA. They're called resolvins, protectins, and myricins, and they actually act to resolve inflammation and promote healing and support our immune system, which is much different than when we think about soybean oil-based lipid products that can actually impair your immune system. And so there is animal model data in using SPMs to treat ARDS, sepsis, and infection, but we're still looking for data in human models and the ideal populations to use these products in. So there is a thought that using EPA and DHA can actually improve outcomes in critical illness, but as I mentioned, we're not sure exactly which patient populations would be most likely to benefit from this. And there has been discussion of a potential for therapeutic or non-nutrition use in the ICU. So not just using a fish oil-based lipid product as part of our PN, but actually giving patients fish oil or IV fish oil. So with that, I'm going to turn it back over to Dave, and he's going to share a little bit of data with us.
All right, thank you. And I realized after I sat down that I failed to introduce myself. So I'm David Evans. I'm a trauma surgeon, general surgeon, critical care intensivist at Grant Medical Center in Columbus, Ohio. We're a level 1 trauma center, safety net kind of hospital, but also I'm the medical director of our nutrition support service which actually manages parenteral nutrition patients across 14 hospitals. So with a wide variety of diagnoses, and it's an interesting process and program. So, but anyway, so to pick up where we left off, so of course, we've talked about how there are different kinds of lipids. Now, when you start to look at the clinical data, it's interesting. I think it probably depends partly on your perspective, what you're trying to show, maybe what part of the world you're in, and what products you have access to. But you'll see literature about these two ideas. One is omega-6 reduction, being that the omega-6s are very pro-inflammatory. We have long-term data showing increased liver injury, for example, with soy oil, a lot of the side effects. And then we also have the idea of omega-3 supplementation. So, and that's been studied both in trials where it's the mixed oil, and then it's also been studied, going pretty far back as a supplement, and of course, whether it's enterally, parenterally, depending on the context, depending on the population. Of course, for tonight, we're talking about parenteral lipid emulsions for TPN. So diets that are high in omega-6 have been known for a long time to be very associated with poor outcomes, a lot of inflammation. Going back to the 1960s when a lot of the Framingham study, other cardiac work was being done, we've known that patients who are getting high omega-6 diets have worse outcomes, really across the disease spectrum. We also know that fish oil, or omega-3s, have these very specific anti-inflammatory properties, and then also have the downstream production of the SPMs and some of these other novel resolvent pro-inflammatory or pro-resolving molecules. So when we look at the literature, we'll see discussion of both of these ideas or both of these strategies, and sometimes they're talking about the same thing, and other times they're not. So we'll try to parse that out a little bit. So one of the newest papers is a meta-analysis published in 2022, looking at from a European perspective, and looking at omega-6 sparing parenteral lipid emulsions, really trying to look at trials that include the blended soy MCT versus pure soy, the soy olive combination versus the other two products, or then those products that contain fish oil versus all the others. And so this is, I know it's a lot, these meta-analysis can sometimes, put some people to sleep, especially when they've had a full stomach and some things to drink. But basically, I'm gonna try to walk you through a few of these. So the first slide, this forest plot, tells us that there's really no difference in mortality when we look at the different lipid emulsions. So I'll try the pointer, see if it works. So of course, when these diamonds don't cross or when they cross the line in the middle, it means that there's no statistically significant difference. So when you have soy MCT versus pure soy, no benefit in mortality. The same no benefit in mortality when it's soy and olive versus soy MCT or soy. And then when you do fish oil containing versus everything else, no difference in mortality in this meta-analysis using kind of traditional techniques of meta-analysis. But when you start looking into the other endpoints, you do find interesting data. So 100% fish oil, PN specifically, does benefit mortality if you give it time to make a difference. So 28 days, you do see a difference. So overall mortality, that diamond is starting to get awfully close to coming off that line, but not quite, so we can't say overall mortality, but the 28-day mortality is coming off the line, and so there is a benefit, and that's specifically for the 100% fish oil, which typically for most of your patients, and we can talk about it a little more, isn't going to be your choice. Now, this is for ICU length of stay. So as we start looking at measures that are easier to move the needle on, so ICU length of stay is reduced with fish oil more than the other strategies. So we see the soy MCT actually, almost leaning toward being a little harmful. The soy olive leaning the other way a little, but clearly well on top of that line. But then when we move down to the fish oil containing PNs, there's a clear benefit in terms of length of stay, and it's interesting. It's a 3.5 day benefit in length of stay, so pretty profound. Infectious complications are reduced with fish oil containing lipids as well. So an odds ratio of 0.65 coming off that line. So definitely a benefit in reducing infection. And that's probably once again because of the inflammation resolving effects of fish oils. So I want to go into really depth. And if you want, even if you know a lot about lipids, I hope I can tell you a little bit about these really interesting trials, network meta-analyses. We're seeing more of these, and I think it's really a fun statistical method, and it took me a little while to wrap my head around it, so I wanted to share this with you, and I hope you'll enjoy it. Now, this is a picture of Lorenzo Pradelli. He's an Italian working in Europe, really, really wonderful fellow, interesting guy, and he's done a lot of in-depth statistical analysis in these topics. And so what I'm sharing now is all work from Dr. Pradelli. But I want to start with before we dive into lipids and all these acronyms and all that, I wanted to start with just kind of a simple question. What blood pressure, and I'm going to dumb it down beyond, we all know it's not this simple, but let's look at what blood pressure medicine would be best? What blood pressure medicine would be most effective? Is it better to take, maybe you're faced with two choices. You could take an ACE inhibitor, or you could take a calcium channel blocker. So if you're into brand names, basically we're looking at, do you want lisinopril or do you want Norvasc? So, okay, that's a simple question, right? Well, this is all made up, but let's say that there's only one trial that's ever been published looking at ACE inhibitors versus calcium channel blockers. Well, if I went to the big meeting and I said, we need to stop using one because one's better than the other, and this is a big deal, people would say, oh, we need more than one trial, and that's not convincing. One trial, how many decisions do we make based on just one trial, right? So, okay, let's say we have that one trial, but I also have 5 trials where they compared, I didn't mention beta blockers, but let's say that there are 5 trials of beta blockers versus ACE inhibitors, and there are 4 more of beta blockers versus calcium channel blockers. Well, could we make some inferences? If A is better than B, is B better than C? I don't know. I mean, on a practical standpoint, we could probably do that, but how do you do that from a statistical standpoint? So that's where a network meta-analysis comes into play. So it's to make indirect comparisons. We've got all these comparisons between ACE inhibitors and beta blockers and calcium channel blockers and beta blockers, but we only have one comparison directly between ACE and calcium channel blocker. So how can we leverage this? And so the network meta-analysis actually brings it all together. So when we look at it, well, now we have a lot of people who got ACEs, we have a lot of people who got calcium channel blockers, and tons of people who got beta blockers. So we have these direct comparisons, that are here. But the question is, can we use the network analysis to make a indirect comparison? So now we can, and they refer to these as nodes. So the statistics are a bit different and a bit beyond what we can probably dive into here. But basically, Dr. Pradelli started looking at these key questions like, okay, we have olive oil, we have MCT in soy, fish, and pure soy. We've got we have a lot of direct comparisons, for example, between soy and fish. Just a little bit between like olive versus MCT, for example. How can we extrapolate? How can we build this network? And then I'm going to focus on infection, and I'm going to focus on ICU length of stay. So here you see we don't even have a study, for example, of head-to-head olive versus fish, but we've got these other connections. So how can we make those direct? So like I said, beyond the scope of tonight, but he calculates this out and comes up with this number called the SUCRA. It's the surface under the cumulative ranking. And basically the computer it's almost, playing an algorithm, playing a game of, one versus the other. And it tells us the probability that something is the best, which sounds pretty good to me. If I'm So in this case, 99% chance that fish oil ILEs, fish oil containing ILEs, have the highest probability of being the best in terms of reducing the complications of infection or sepsis. So 99% for infection, 83% for fish oil. And why is that weaker for sepsis? Probably because they have more infections in the data set overall. So just like simple statistics, when you have a larger sample size, you're going to get more precise results. What else did he look at? So he looked at the length of stay. So a 77% chance that fish oil containing ILEs have the highest probability of being best when it comes to ICU length of stay, and 93% certainty that they are likely to be the best for hospital length of stay. So pretty convincing stuff. I mean, you know, that means there's a 7% chance that they're not, but that's how they do this analysis. Interestingly, while I told you that we couldn't show mortality in the traditional meta-analysis, we can show some signal here. So fish oil containing ILEs, 76% chance that they are the best in terms of reduction in mortality. So I think network analyses are fun. I think we're going to see more of them in critical care. And you know, when we start making these complex comparisons between multiple things. So I hope you enjoyed that, and I hope it wasn't just review for everybody but me. So anyway, I also wanted to share with you, this is data from Paul Wischmeyer and Dr. Haynes at Duke, Kristen Haynes. They had one of the first really large United States data sets looking at the use of SMOFlipid. You know, a lot of the data that we had was international. And as much as we shouldn't, you know, when we read studies from around the world, you know, we often tend to say, well, those aren't the same patients, or they do it differently, or this or that. And so this gives us good, you know, US data that, you know, is probably a little more similar to how many of us practice. And they looked at their transition. They went 100% from soy oil containing ILEs over to the 4-oil lipid emulsion. And they saw statistically significant reductions in the length of stay, in the ICU length of stay, and interestingly, UTIs. And UTI is interesting to me because it always pops up, urinary tract infection, always pops up in studies of nutrition. And I always think, what's that have to do with nutrition? But interestingly, even if you look at the older malnutrition literature, urinary tract infections are the most correlated with malnutrition of all the infections we see in our hospitalized patients. So, I always think of wounds. They're up there. They're up there, but they're not quite as much as urinary tract infection. So I know we're at the SCCM meeting, so we can't get through this without talking about some ARDS, right? Or some ventilators or something. So interestingly, and this trial isn't really clinical parenteral nutrition patients, but just speaks to the mechanistic benefits of fish oil. So randomized control trial in Egypt, they took 60 patients. At my hospital, we would call these intermediate patients. These are patients on like a high flow nasal, they're on like 4 to 6 liters nasal cannula or a Venturi mask. Maybe they're even on med-surg. They're not quite on the high flow yet. And but they're trying to prevent them from needing the ventilator. They're trying to prevent them from needing BiPAP or high flow nasal cannula. So they're basically trying to intervene early on COVID-19 to prevent the worsening of oxygenation. And interestingly, so we don't normally think, oh, let's do a lipid infusion, right? Like that's not our go-to for this patient, but that's what they did. So they studied a lipid infusion versus a saline infusion. They ran 100 milliliters over 8 hours, so they're trying to control for the volume. And they found that the use of the 4-oil ILE reduced the need for ventilation from 47% to 20%. So they did not achieve statistical significance in that. Now, when they did look at their sub-analyses, they looked at PF ratio, so the PaO2 to FiO2. So that's a measure, for those who might not be doing this every day, that's a measure of how severe the oxygenation problem is. basically the ratio of the oxygen in the blood to the oxygen being delivered. And they saw that by both by day 5 and by day 7, there was a statistically significant improvement in the P to F ratio with the with the 4-oil lipid infusion. So that's pretty interesting. And also that these patients had lower improved respiratory rates. Now, I don't practice in children, but I did want to share with you, Dr. Haynes, Dr. Wishmeyer at Duke also looked at their pediatric subset. I went to medical school there, so I'm always partial to anything from Duke. You know, it's kind of, I feel like I have a part in these trials, even though I had nothing to do with them at all. But anyway, so in the pediatric ICU, they looked at these same questions. They looked at the soybean oil versus the 4-oil lipid emulsion, and they looked at all of their outcomes. And so they saw improvements in ALTs, alkaline phosphatase, total bilirubin. They saw a shorter length of stay. We see that very consistently across almost any trial you look at in the lipid arena. And hey, there are those urinary tract infections again, fewer UTIs. So, you know, impressive once again. Now I wanted to shift gears a little bit and talk about essential fatty acid deficiency, because I think this is an interesting area. I'm not sure that there's a lot of clinical significance to what I'm about to tell you, but for a few points. So one is if you're dosing 4-oil ILEs appropriately, you're still giving 15% fish oil, or you're giving 15% fish oil. You're still giving soy oil too, so you're getting the ALA and you know and the linoleic acid, so you're getting the essential fatty acid delivery that you need. So it has plenty of it, and that's true of any mixed oil that we really have. We have enough soy that we don't have a problem. Now, even 100% fish oil, this often gets overlooked, has very low amounts of LA and ALA. Now, 100% fish oil, you know, you typically see it as a rescue lipid, pediatric populations, you know, not as a routine thing. I mean, I don't do pediatrics, so somebody might say, oh, it's routine for this or that. But, you know, but that's there. But the other interesting thing that they've seen is that even patients who've been supported with 100% fish oil for longer periods of time in the real world do not appear to be developing essential fatty acid deficiencies. Now, I can't tell you that it never happens, but it's not really being seen. And so this group from Boston, that's the lower of the two papers, the Inez Bustillos, and this paper goes back to 2018, started publishing and observing this data, this observation that 100% fish oil was not leading to essential fatty acid deficiency. And there are pathways that have been elucidated. You know, we all learn that, well, humans can't make ALA and linoleic acid. That's why we need them, right? That's what we learn. That's like what our textbook says. But there actually appear to be some retroconversion pathways. And in the mouse trials done in Boston, they actually fed the mice 100% fish oil for 5 generations. So, like, you know, if you are what you eat and you're also like, you are what, like, your parents, like, for 5 generations, there was no, you know, soy, no other fat, just fish. And yet they did not develop any clinical signs or biochemical measures of essential fatty acid deficiencies. So pretty interesting. This is the pathway. I know it's kind of small for those in the back of the room, but basically arachidonic acid appears to be back converted to linoleic acid by these retroconversion pathways. And then the other is that you know, the downstream products of I'm lost there. There's something wrong with that. Anyway, trust me on this, that you can make both of them. So anyway, sorry about that. I think I dropped something off the side. We also know, though, that with the 4-oil lipid implementation, we see significant cost savings. Now, you'd say, well, why is that? Well, first of all, there isn't a huge price difference between the lipid emulsions, especially in the whole scheme of things. It always kills me when we argue about For example, I got really beat up about the cost of enteral immunonutrition versus like standard tube feeds. And the whole budget of these kinds of things in the hospital is like nothing compared to a lot of the chemo drugs and other things that we're doing in the hospital. We spend like over $1 million a year on Pip-Tazo, so what's the big deal? But anyway, but the real cost savings is often in the reduction in the length of the stay, because for those of you who are practicing in the US, you may know that for most patients, typically the hospital gets paid a charge based, or gets paid like a reimbursement based on like the diagnosis. And so if the patient does well and they get out of the hospital relatively quickly, you usually win, you turn a profit. If the patient has a complication, a long length of stay, then the hospital kind of loses out. So usually even if you spend a little bit of money early up to improve the quality, if your length of stay is shorter, your outcomes are better, these are all going to be cost-effective interventions. And that's true for a lot of different things, but clearly that data bears really out across the world for oil lipid emulsions. And with that, I'm going to hand it back to my colleague.
Okay, so now that we have seen some more of the recent data, let's talk about what our guidelines are, because we always hear a lot about, well, there was this study and that study, but what are the actual recommendations? So Aspen released a set of critical care guidelines, which were an update to their 2016 guidelines at the end of 2021. And in these guidelines, they suggest using either a mixed oil ILE or 100% soybean oil ILE during the first week of ICU admission. And this on its own doesn't sound like much of a recommendation, but if you think back to the previous set of guidelines where they actually recommended withholding lipids for the first week of ICU stay, and that was basically off of some pretty flawed data about soybean oil containing lipids increasing the risk of infection in that first week. And it was actually the only recommendation in those guidelines that did not have consensus. So although this doesn't sound like a very strong recommendation, it is still weak qualitative evidence. It's quite a bit different than the 2016 guidelines. But when it comes to the actual type of lipid that we use, they suggest either a fish oil or non-fish oil containing ILE. And these guidelines have come under quite a bit of critique because they excluded many studies. There were certain patient populations that the studies just weren't robust enough for the pre-specified methodology of the guidelines. And as I mentioned, these came out at the end of 2021, so some of that newer data that Dave presented is not covered in these guidelines. Meanwhile, in the rest of the world, they have been using alternative lipid emulsions for many, many years. And so ESPEN, which is the European Society for Parenteral and Enteral Nutrition, released an update to their critical guidelines in 2023, and they have a little bit more specific recommendations. So they suggest a max dose of 1.5 grams per kilo per day of lipids in the ICU, and that most patients are going to get 1 gram per kilo. And so you can see that we're targeting those higher lipid amounts versus what we saw with the soybean oil-based lipids. They do say that you can use lipids that contain DHA and EPA, and they have specific fish oil dosing. And they specifically say that we should avoid 100% soybean oil containing lipids due to their pro-inflammatory effects. These guidelines also state that the data that we have on these products, a lot of the studies have a lot of bias and fairly low level of evidence, which I think kind of indicates the need for such things as those network meta-analysis that Dave talked about. But they do suggest using a blend of fatty acids, including things like MCTs, fatty acids, omega-3 polyunsaturated fatty acids. But one of the things that I think it's important to remember about the European population is that they're not as concerned about whether you should use fish oil containing or alternative oils versus soybean oil, because they're really not using soybean oil anymore. So the American guidelines are answering a question that the Europeans have essentially moved on from. And I think this is indicated as well from the German guidelines, which came out in 2019. And they are working on some updates that will specify which lipids specifically should be used. But what they do say is that you should avoid the use of 100% soybean oil. So again, this guideline is quite a bit older than even the Aspen guidelines, but they're again not recommending the use of soybean oil-based lipids in the ICU. So kind of to sum up the guidelines, I think the Aspen guidelines are kind of out of date, and again, focusing on a question that I think has been answered, and there is enough data now to support that some of these newer lipids, especially the ones containing fish oil, do have supportive data. And overall, our clinical practice should be shifting away from the use of soybean oil-based lipids. And if you are still using those regularly in your ICU, I think you need to kind of take a step back and think about, well, why are we doing this? Because there is data that they're harmful and they don't offer the positive effects of the other lipid emulsions. So to shift gears a little bit, the pharmacist in me is going to come out. We're going to talk a little bit about lipid compatibility and stability with these new products. And I think education is extremely important now that we have so many lipids available in the US, because one of the common things I hear when we're providing education is, I don't know what kind of lipid we use. We don't compound our PNs in-house. CAPS makes them, or some other outsourced pharmacy makes them. Aren't all lipids the same? And we've shown that the components are different, the clinical outcomes are different, the dosing is different, but also compatibility and stability is different with these products. So I've got some examples here of some cracked and creaming lipid emulsions. The second one is just showing some precipitation. And then the far right picture is a lipid-containing PN that was going through a filter, and that discolored area is an occlusion that the filter caught. So had the filter not been there, that would have went into the patient. So I think the big takeaway from this is that all lipid formulations are not the same. You can't extrapolate data from one product to another, and you shouldn't make assumptions. These are patients' lives, and we want to do the safest thing possible for our patients. So when you're thinking about compatibility and stability, I feel like in school, and what I see a lot of other colleagues and people do, is they say, well, I'm just going to look in my online database and I'll see if I can Y-site these things, or if I can mix this into this. And you pull up your trissels and your LexiComp, and it gives you a little green check, and you say, I'm good to go, and I just move on. But the problem with that is you have to think about, especially with PN, this is not one medication and one concentration. You want to see which products they were testing. A lot of the data in the online resources or in the compatibility and stability handbooks is over 20 years old. A lot of these products are not available on the market anymore. You want to think about the concentrations. Were they dosing with the same concentrations of dextrose, of amino acids? What about their cations, magnesium and calcium? Do these formulas that are in the databases correlate with contemporary formulas? PN practices and nutrition practices have changed a lot in the last 20 years. You also want to think about what type of testing is performed, because I showed you those images, and to be able to get very, very, very visible pictures, you have to manipulate those bags quite a bit. My colleague and I made those with extra products that were not going to be used in patients. And a lot of the data indicate that you can't actually see when these incompatibilities happen or when the formulations become unstable. By the time that they're unstable, things are very bad. So you want to think about what type of testing was performed. Were they just doing visual inspection? Were they just looking at it? Or were they doing more elaborate testing? So when we think about our soybean oil-based lipids, as I mentioned, most of the things in trissels or the other compatibility handbooks are going to use soybean oil, because this is the data that we have. It's the product that we've used the longest in the US. Most of this data is based on physical compatibility alone. You can also request from the manufacturer the compatibility data for the olive oil, soybean oil lipid emulsion, but I will tell you that they also only evaluated physical compatibility, and that was via visual inspection only. There is some new data, excuse me, I'm kind of losing my voice. There's some new data with the 4-oil lipid product, and I'm going to share snippets of that tonight, but if you are interested, you can reach out to the medical affairs at Fresenius Kabi, and they will be able to share the full data set with you. But one of the things that they talk about in their data is that, you can look at things to see, you can do visual inspection to look for incompatibility, but you can't actually see precipitation in lipid-containing emulsions because the white color, you're just not able to see it. So they actually did a little bit more robust testing where they tested the same 2-in-1 formula that didn't contain the lipids to look for precipitation, and then they also tested the TNA, and looked at the stability of the emulsion. So they did look at physical compatibility, including visual inspection, but they also looked at lipid globule distribution. They looked at the mean droplet diameter, the PFAT5, which is kind of considered to be the gold standard for evaluating lipid stability. They looked for subvisible particles, and all this was in line with the chapter with USB 788. One of the other things that's really nice about this is that they tested multiple amino acids. So we said that all lipids aren't the same. Well, guess what? All amino acid products aren't the same either. They contain different concentrations of electrolytes, and even things that you would think would be very similar can have very different compatibility and stability results. So this is an example of Y-site compatibility with the 4-oil lipid with clinosol 15%. And they did test more products than I have listed on here. I kind of just picked out some that I think you commonly use in the ICU. Several things were reassuring to me. We've got cefepime on here, cisatracurium, dexmedetomidine, which is a newer agent, and we don't have a lot of stability data with some of the older lipid products. Dopamine, metronidazole, norepinephrine. So for patients in the ICU, if you do have limited access, you may be able to run your PN with your pressors. They were incompatible, though, with meropenem, micafungin, and vancomycin. And there was no data on fentanyl and piptazo, so I asked about this when we got the data, and unfortunately, there were limitations on controlled substance testing, so that's why fentanyl was not on there, and then piptazo was on shortage during the time the testing was conducted, and they were unable to obtain it. But I'm hopeful in the future that we may get some of that data. But look at the difference here with a different amino acid. So a lot of it's the same. So this is plenamine 15%, but you'll notice cefepime is incompatible, but vancomycin is compatible. So again, you need to know what products you're using at your institution, and you're gonna have to go a little bit deeper with these different lipids, and ask your pharmacist to go deeper if you're not a pharmacist, if you're a dietitian or a physician, to make sure that if you are Y-siding things in with the lipids, or if you're using a TNA, that you're doing this safely for your patients. So we think about practical considerations. So which lipids do you have on formulary at your institution? Some of this may be controlled by your hospital's P&T committee. Other places may outsource P and compounding, so it may depend on which pharmacy you use to compound. As Dave mentioned, when we think about cost, I feel like a lot of times from the pharmacy perspective, what we hear about is acquisition cost. So cost savings by using things that improve outcomes is more difficult to prove up front. But the lipid prices, I think, are a little, kind of leveling out at this point in time. But a lot of that may depend on your contracts and other things at your specific institutions. But you want to consider clinical outcome data, not just the acquisition cost. You also want to think about how you're using these lipids. So I can speak for my institution. We carry 3 lipids on formulary in the adult population. We do TNAs, which are total nutrient admixtures. We're all in one bag. With the 4 oils, because we were waiting on this compatibility data, we do that as a 2-in-1. We were Y-siding the lipids in. And so you have a lot of flexibility with that if you do have to infuse a product that's not compatible, because you're only going to give the lipids over a 12-hour time period. But running different processes sequentially can really increase the risk for errors as well. So it may be more flexible, but also more error prone. You really have to think about what's going to work best at your institution. From a patient perspective, you want to think about what type of IV access is available. In a perfect world, we would never run anything with a PN. We would always have a dedicated line. But unfortunately, that's not the case in a lot of patients who may have, especially in the ICU, who may have a lot of drips, a lot of antibiotics and other things. So you need to think about what type of line you have and how many lumens you have. Also think about other types of IV medications. You know, work with your pharmacist to see if there are different types of medications that you can cluster the administration time, so that you're not having to interrupt the PN, because PN should not be disconnected and reconnected due to infection risk. And then you also want to think about lipids. If you're infusing them outside of the PN, they should be infused over 12 hours. If they're in a TNA, they can go for 24 hours. So again, we want to think about the compatibility and stability data. And I guess my overall point with this is that you're going to have to, with these new products, you're going to have to dig a little bit deeper than those classic compatibility handbooks that we have previously been using. Some institutions may have their own internal data. I would encourage you that if you work at a facility that you have internal data, publish that, because it could be very helpful to other institutions. But the best place really to get a lot of this data at the present time is to contact the manufacturer directly for all of the products that you're using. And this data generally can't be shared, it does have to be requested. So when you're using these newer lipid products, I'm supportive of that. I think there's evidence for that, but you have to take all of these factors into consideration. You also have to think about confusion among your staff when you have multiple lipid products, when perhaps people were used to thinking that there was just one certain type of lipid, and now we're dosing different types of lipids, you're compounding with different types of lipids all in consort. I think it's really important also to educate your clinicians and your staff, not just about the practical and the ordering perspective, but also on the clinical differences in the types of lipids, because I still hear a lot in our ICUs that there's concern about using lipid emulsions, that we think that they cause liver failure. And most of the data that people are citing is the soybean oil-based data that, as I mentioned, was flawed and is really old. We have newer products, and it's our job to educate our non-nutrition colleagues about these new data. As I mentioned, infusion time with lipids is important also. If you are using Y-sided lipids, they should only hang for 12 hours. And the reason for this is because it's that isotonic solution that I mentioned earlier. When you mix lipids in the PN, the overall formulation is so hypertonic that it will still be a hypertonic solution. That's less favorable for microbial growth. But if you're hanging the lipids separately, they should be limited to 12 hours. So as I mentioned, for some things that may be incompatible, that does give you a 12-hour window if you need to Y-site something, that you may be able to schedule certain medications. And then lastly, I had the picture of the filter. Aspen does recommend the use of a 1.2 micron filter for all PN solutions, including those with lipids, but also without. And lipids are going to prevent particulates, microprecipitates, aggregates, and large fat dropules from reaching systemic circulation. So if there was an issue with your formulation, the filter is kind of the last line of defense for your patient. And so the last thing I'll mention here is the International Lipid Summit. This was a meeting convened with nutrition clinicians from around the world at the end of 2022, and Dave and I were both lucky enough to be able to participate in this, and we are working on a manuscript right now to publish the summary of this. But the key points of this lipid summit were really a lot of the things that we discussed tonight. That lipids are an integral component of PN. You know, it's not something that is optional. They should be part of the PN prescription. That we should consider the use of fish oil containing lipids, even in the first week of ICU stay, because there's no data to show that that is harmful. There's more accumulating evidence that fish oil containing lipids offer advantages over non-fish oil containing lipids. And I would say that since we've had this meeting, there's even more data to support that. We should be limiting the use of soybean oil-based lipids. And again, I think it's the US that's kind of the holdout on that, where we're still using those quite a bit. And then when we do use lipids, we want to make sure that we use them safely. We want to make sure we're considering compatibility and stability with other medications, that we're using them for the appropriate infusion time, and that also we're using filters. And so that is going to wrap up our talk. We'll open up the floor for questions.